I would like to welcome Dr. Banerjee to the chair. Our next chair is Dr. Teeluck from Hausenloy. He is an eminent professor and academician. He is a professor in cardiovascular and metabolic disorders program, Duke National University of Singapore, and is also a professor, Institute of Cardiovascular Sciences, University College, London, United Kingdom. Currently, he is the director of National Heart Research Institute, Singapore. He has 338 peer-reviewed articles since 2002 and guided 11 PhD students and 16 MD students, and he has also earned a total research grant income in Singapore as PI over 17 million Singaporean dollars. I would like to welcome Dr. to the chair.
Me and Ashima plan to interchange our speeches, but you can see she's much shorter than I am, so we just decided to keep it separate. But yes, I've been blessed with a massive opportunity to introduce Dr. Gunness today. Unfortunately, Dr. Gunness is in France today. Due to unforeseen circumstances, he will not be able to join us. But luckily, due to the advent of new technology, we can appreciate him here and we'll be able to hear what he has to say today. So yes, I'm going to keep it quick because Dr. Gunness ends at 2 o'clock. He cannot attend the entirety of the meeting, but he is a distinguished cardiac surgeon and the director of cardiac services at the Cardiac Center in Pamplemousses, Mauritius. I hope I pronounced that right. He has performed the first open heart surgeries in both Madagascar and Botswana and continues to conduct cardiac surgery missions across the Indian Ocean. He is also an honorary professor of medicine at the University of Mauritius and an active researcher and a member of several international societies, including the American College of Cardiology, the European Society of Cardiovascular Surgery, and the Pan-African Society of Cardiology. Beyond surgery and research, Dr. Gunness leads important public health initiatives as president of the Heart Foundation and Diabetes Foundation in Mauritius. Please join me in welcoming Dr. Teeluck Kumar Gunness. I hope we can touch, I just want to say one thing, I hope we can touch our hearts today like you have done with many other people in the past. Thank you.
So thank you for this introduction. I am very honored to be present with you. I apologize for not being present physically. Unfortunately, I had to come to Europe for some personal work. I'm going to talk about cardiac tumors and our experience at the Cardiac Center. But first, a few slides. This is my plan. There will be an introduction, the clinical aspects, and the surgical intervention. Next one, please. I would first like to take you to some figures. Next slide, please. Yes. So this is the Cardiac Center. The Cardiac Center is located in the north of the island, and the rear part of the SSR hospital. We have some 15 ICU beds, 3 operating theaters, 2 angiographic departments, and some 50 inward patients. And we do some 1,000 open heart surgery every year. This is quite important. If you take France, for example, there are some 60 cardiac centers in France, and not more than 10 of them do about 1,000 open heart surgery every year. So we are quite busy at the cardiac center. I'm going to talk only about cardiac surgery, but we also do angiography and angioplasty and insertion of stent. For example, we will do about 2,500 angiography every year and some 1,000 insertion of stent everywhere. So we are a tertiary center. We have patients that are referred. And most of our cases, they are bypass surgery. Next slide, please. You will have more than 80% of the cases of bypass surgery. This is because of the high incidence of diabetes in Mauritius. But we also do all the other types of surgeries that is done in the other cardiac centers, like mitral valve replacement, or mitral valve plasty, aortic valve replacement, double valve replacement, combined cases CVD associated with valve replacement or valve plasty, we do cases, pediatric cases as well. Next slide. We also do some a very small amount, you see there, 1% of our cases, they are very rare cases like tumor resection or a repair of aortic dissection. Next one, please. The cases that we do and that we like to do, actually, they are very challenging cases. They are the aortic dissection repair. We would have a lot of aortic dissection in Mauritius, but many cases we get from Madagascar, and they fly to Mauritius for aortic dissection repair. And the myxoma resection, which is one type of the tumor that I'm going to talk about, also we do some 5 cases every year, and these cases are also very challenging. Next slide, please. Now, I'm going to come directly to, after this introduction of the cardiac center, I'm going to come directly to the tumors. They are rare tumors compared to the whole all tumors. They represent less than 0.02%. They are extremely rare. So this is very surprising. How can we explain that? Because the heart is this organ which receives 5 liters of blood every minute. How come they are so little, that rare reactive tumors of the heart? I don't have the explanation, and but might be because it keeps beating every minute. It is the only organ of the heart that just keeps beating 70, 75, 80 times a minute, and the blood doesn't have the time to stay there. The lymphatic system is very active in the heart. Might be these mild bloodlets that we don't see that in tumors of the heart. We have 2 types of tumors of the heart. We have the primary tumors, and then we have the metastatic tumors. The metastatic tumors, they are most frequent. They are 30 to 50 times more frequent than the primary tumors. Next slide, please. Among the primary tumors, most of them, 75% of them are benign tumors, like myxoma, like lipoma, like fibroblastoma, or very rare tumors like fibrohemangioma or teratoma. So these, you will see there, the green part, they are myxomas. 50% of these benign tumors, they are myxomas. Next one. The malignant primary tumors, they can be sarcoma, they can be pericardial mesothelioma, they can be primary lymphoma, which are very rare. So these malignant primary tumors, they are 25%. Among the primary tumors, malignant is 25%, and benign is 75%. Next one, please. Now, the metastatic tumors, they are mostly by contiguity. For example, when you got a pulmonary neoplasm or you got a renal neoplasm, by contiguity, they will come to the heart. You can see on this slide, the stage 1 is a renal tumor, and then it will grow, and then it will come through the pulmonary renal vein and the vena cava, and it will go upward towards the right atrium. This one is something that is quite different, and emotions. We have, tumors, kidney tumors, renal tumors that are going to grow through the vena cava and come to the right atrium. As cardiac surgeons, we are involved in rejecting the part that is in the right atrium, but then the other surgeons will take care of the vena cava and the kidney. So one surgeon will remove the kidney monkey, and the vascular surgeon will do and try to do something on the vena cava. Next one, please. So this you can see here, you've got a left kidney tumor that is going, left kidney tumor that is going through the renal vein, and that's going to the pulmonary vein, to the vena cava, and like this it will go up to the right atrium. These cases are very challenging cases. We are there to remove the part of it that comes to the wrong atrium. We try to go as far as possible beyond the diaphragm to the vena cava to remove this part, which is the vena cava. But then vascular surgeon must come, and either we open the vena cava, remove the vena cava part, and then the urologist will remove the kidney. They are quite challenging cases, quite long cases. It's very rare that we will do this in one single sitting. Very often we will do in two sittings. The first one will be the cardiac one, and then the second one will be the abdominal one. Next one, please. Leukemia and lymphoma are quite rare. Very often they are at end stage, and in these patients at the cardiac center, mainly because we have a recurrent pericardial effusion. We will be there to do tapping. We will either by the cardiologist do intervention. We will do interventional tapping by needle, or if there is repeated pericardial effusion that can lead to tamponade, we will do open heart surgery, and we will deal by doing a window, a small window between the pericardium and the peritoneum. You can understand, you must understand, that we are really at an end stage situation, and this is only to avoid a tamponade. Next one, please. Now, I'm coming to the clinical aspects of tumors of the heart. In general, there's nothing specific. There's nothing specific. It doesn't depend on the histological nature of the tumor. It depends more on the size of the tumor. It depends more on the location of the tumor, and it depends more on the aspect of the tumor. And I'll go through a few slides on this part. Next one, please. So we are concerned with the size of the tumor, the location of the tumor, and the aspect of the tumor, whether it is solid, friable, and so on. Next one. So, also, next one, please. So here, the location of the tumor can be within the cardiac chambers. In the chambers itself, most frequently the atrium, the diaphragm, and the wine. Very rare ventricles. It can also be in the muscle, in the myocardium, and then it can also be outside the muscle, that is between the muscle and the pericardium. Next one, we will come back to the cardiac symptoms, but let us see what can be the extra cardiac symptoms of these tumors. Of course, we can have thromboembolic events. If we have a dismal tumor in the heart, if it can be small parts, it can go up, and they can give embolic events in the limbs or in the head, in the brain. We can have embolic events. And if, for example, the heart is heterogeneous, these tumors will very easily give small parts that can go away. Most of the time, either on the heart or in the left kidney, we can have easily embolic events. But then we can have several symptoms like fever, like chills, like lethargy, apathy, weight loss, just like any other tumor. Most of the time, I will talk later that we will discover these tumors incidentally. Next one, please. So when they are in the heart chambers, we can have a valvular stenosis. We can imagine that there is something there that is going to prevent the normal functioning of. For example, if you've got a tumor that is near the transducing valve, so this tumor will prevent the normal functioning of the tract. So it can provoke a valvular stenosis, it can provoke a valvular insufficiency, it can go and protrude in the valve and leave the valve open, and you can have signs of macrocytic regurgitation or mitotic regurgitation or outing regurgitation. But then it can also be in the chamber, and it can limit the preload, or it can form an obstacle for injection. Now, limit the preload is very important, especially in the right atrium tumors. In the right atrium tumors, you can have tumors, and the right atrium is completely filled with that tumor. So the preload is very low. Right? So with standard, the right ventricle stops from coming well. The right ventricle, there is, it will have less blood, and this function will go down. Now, when we do surgery, and when we remove this tumor, we must be very careful, because we can end up with a right ventricular failure. So we must do this. It's very important to note that when we are going to reset a one atrium tumor, we have got to be very careful and be careful with ventricular failure. Now, we have one case like this in Botswana. It was a massive tumor in the right atrium. We removed, and it was going in the trachea. We removed everything. Unfortunately, we lost protection in the cancer care because there was a right ventricular failure, and we had not many ways to control this right ventricular failure. You know, this one is even got left ventricular failure, breathing motion, breathing motion. We will use an intraventricular pump to go through this catheter pump, left ventricular failure. But for right ventricular failure, there is no intraventricular pump. We have got only medications to help us. And in this case, there was so much blood of the removal of this tumor on the right atrium, so much blood going to the ventricle that the right ventricle just failed. Now, next slide, please. Now, when the tumor is next slide. When the tumor is in the myocardium itself, it will provoke arrhythmias and will provoke reduced function of the heart. This part of the heart, this part of the myocardium, which has got the tumor, will not contract well, and there will be reduced function of the heart. They are very difficult to remove because when we put this tunnel, it's very difficult to know where they are exactly in the myocardium. Sometimes it can be the posterior aspect of the myocardium, and they are very difficult to remove. We have a reason of the myocardium, and we replace this myocardium by a patch of not like the myocardium itself, and it's not very easy. It's not very easy. It's still very challenging surgery. There are, for example, sometimes it can be in the left ventricle, and you've got a lot of septum, and the septal artery is going in the septum, and we can damage one of these septal arteries, and we can end up in a massive infarct of the heart, and we can remove the patient. Next slide, please. So, we will now concentrate more on the primary tumors of the heart. The primary tumors of the heart, as I mentioned to you, 75% of benign tumors, and most of them are represented by myxomas. And the next one, the other one is lipomas, and we can have lipomas which are, of course, the name itself is a fatty lump, which is very, very strong. It can be within the myocardium. It can be within the myocardium. Most of the time, we just leave it like this. We try to control the arrhythmias, but sometimes it can come outside the myocardium and it can compress the heart within the pericardial side. And this is an indication for surgery. We will go in, we will remove, we try to be thorough as possible. We will remove the lipoma just to prevent cancer, and we will leave open the pericardium. And very often, we will do a window between the pericardium and the pleura, so that if it is structurally, it can go in the pleura and it can help to prevent a cancer. Next one, the papillary fibroadenoma is 80% of them develop from the arms, mostly from the left chambers. Mostly the abdomen is involved. In 45% of cases they are pedophilic, and of course they can just break and go and provoke ischemia anywhere, in the limbs, in the brain, everywhere. And they can provoke vascular destruction, they can have thromboembolic events. Next one. Very rarely, in 25% of cases, we have a malignant primary tumors. Sarcoma, we are around the middle-aged adult, and sarcoma from the right atrium can extend to the pericardial side and be responsible for that. And can be responsible for some radiation studies. I have a meeting for malignant tumors like sarcoma. Most probably these patients pass away before they have the opportunity to come to the cardiac surgeon consultation, but then doing a lot of ways to treat these patients. I have read that sometimes they can go for a heart transplantation, they can be indications for heart transplantation when they have reactions. Next one, please. So, this one, pericardial mesothelioma, just like the pleural mesothelioma, they come from the pericardium, and they can provoke tamponade, they can provoke pericarditis, which is inflammation of the pericardium, or they can provoke pericardial fibrosis, and then we can have constricting symptoms like dyspnea, like hepatopathy, like distended bowel, like generalized edema. And this one, we will be palliative, we will try to help by removing the constriction around the heart. And when we can do it, we can remove, we can peel, and get rid of the constriction and the cardiac. Next one, please. I am now going to talk more about lymphoma, and the rest of my presentation will be on lymphoma, which is where we have more experience in the cardiac center, and we have been very involved in myxomas. So myxomas are benign tumors, and in most of the cases, I would say 98% of cases, they are benign tumors. But some of them have been classified as malignant. Whenever we take a myxoma, we will send to the other part and do the analysis. Now, they can be found, they are benign tumors, but we are going to remove them. They can be found for patients. We can remove aneurysm. I've got a very sad case. This is a 21-year-old patient. She was at the beach at Blue Bay in the south of the island. And she just collapsed, and she was brought to us, and she went to New Hospital. From New Hospital, they did the echo, and they saw that there was myxoma of the left atrium. They sent the patient to us, and we didn't have time for surgery, because the whole myxoma just break went to the home and we lost the patient. So you see, they can be fatal, and I still don't know in this case, 21-year-old. Now, they can also provoke obstruction of cardiac chambers. The mixed mind very often like a bell, and it will, with each contraction, it will go into the heart. Then, when there is relaxation, it goes out of the heart and so on. So it can provoke stenosis of this valve. Now, next one. Most of the time, they come from the fossa ovalis. You know, the fossa, this is this small part of the atrial septa, the fossa ovalis, and they develop from embryological mesentematous tissue. You can see in this schema where most of this myxoma they come from fossa ovalis. Sometimes come from the roof of the left atrium. They are very rare, but I would say 98% they come from the fossa ovalis. Next one, please. So the risk factors were more common in male patients, 30 to 60 years old. This is when most diabetes prevalent, and there can be factor forms. We have studied in this. This is the cardiac complex. We have the factor forms of myxoma, where several members of the family they have a myxoma. Very often, when we see a myxoma, we will try to check if the rest of the family whether they are not myxoma. We must always have this in mind. The next one, location. Next one, please. Location of myxoma. Most of the time, 75% of cases they are in the left atrium, and then they can also be in the right atrium. 20% of the cases in the ventricular cavity. 5% of the cases here they are more challenging. We try to remove them by going either through the trachea valve or through the mitral valve. But what is very important is that what we resect in this myxoma, we must always resect the base of implantation. If we don't resect the base of implantation, the myxoma can grow again. Now, it's very rare that we have a myxoma in two chambers at the same time. I have never seen it, but it has been described. Next one, please. 75% of cases, they are penetrated, sometimes going in and going out of the mitral annulus, floating in the left atrium. They are very scary when we see them, and they are real emergency. We are going to go and remove them very quickly. Small, very few cases are not penetrated, and they will stay in the fixed position. They form part of the wall. There are, next one, 4 different aspects of this myxoma. They can be pixoid and gelatinous, and of course they can be source of thromboembolic events. These ones, next one. But they can also be solid, smooth and firm, and solid, and close the mitral aneurysm and be responsible for mitral stenosis. Sometimes, they can go and just get stuck in the mitral valve. This also has been described. It gets stuck on the mitral valve, and it's really a very, very emergency situation. We have got to remove this because the patient is passed away. You can imagine that the mitral valve is closed completely. The myxoma is closed in the mitral valve. There is no blood going from the left atrium to the left ventricle. Next one, the other aspect, third aspect, they can be primary and irregular and high risk of thrombotic. These ones, they can be malignant. The malignant ones, they are like this, they are primary and irregular. They can also be calcified myxomas. Next one, the diagnosis, they are incidental findings, except if it is a thromboembolic event in the brain, for example, then we will always do cardiac echography, and we very often have cases like this where patient came with a bowel problem, and then I've got one case like this, came for another problem. They read this was the CT, the CT, but then very incidentally, the CT went a bit above the diaphragm, and she saw this big tumor, and we saved the patient like this. And there was no way that we knew there was a big tumor. She was just doing this CT, but then the one section went above the diaphragm, and this is where we saw the big tumor. Now, next slide, the symptoms will depend, again, location, size, mobility of the tumor, and on the physical aspect of the tumor. I've gone through all this already. Next one. Next one. So, you can have cardiac failure. You can understand that if this big tumor goes in and out of the mitral valve, it can cause in mitral stenosis or a tricuspid stenosis. It can cause cardiac failure, dyspnea, symptoms, with peripheral thromboembolic events, but generalized symptoms, like I said before, lethargy, fatigue, fever, is ultra. Next one, there is no specific test, no specific blood test, nothing specific there. We can have isolated raised ESR. Very rare we raise ESR, we are going to a cardiac group. All we tell is 6, anemia, thrombocytopenia, but really I don't see people when there is an anemia going to a cardiac echo. Could be a good practice, but they have been described like this is really not specific at all. Next one. So the gold standard remains the cardiac echo, which is going to show us the size, the aspect, the structure, the mobility, and the style of his tumor. This for the surgeon is very important. The site of insertion, because we will have to remove this site of insertion if we don't want recurrence of the tumor. There is one case in motion where we had recurrence of the main tumor, most probably because we didn't remove the whole insertion area. Next one, and then we can also deal with the CT scan. The CT scan area more to help us about the coronary arteries, because in these cases we don't do coronary angiography, we will not go for coronary angiography. It can be dangerous, but we do CT scan to see whether the coronary arteries are calcified or not. If they are calcified, we will most probably go and do a coronary angiography, but with young patients like this, we don't think a lot of coronary arteries. Next one. The differential diagnosis is very important. We must be careful that it's not an endocarditis. We must be careful that it's not a thrombus. And it's relevant. We have the cases like this. We discuss among ourselves. We see the mobility of the mass, and when we feel it's more like a thrombus, we will put the patient on anticoagulants and avoid going for open heart surgery. So I come to the surgery, the third slide. The surgery, next one please. So we want to be very comfortable. We go to median sternotomy, and we will relay both the superior vena cava and inferior vena cava, and we will isolate these two vessels. Of course, we do the outer, and we will go on coronary bypass. Next one. So here depends how we manipulate the two vena cava and how we are going to isolate the two vena cava, because we don't want any blood to come to the right atrium, right? So then what we do most of the time, we will go through the left atrium. Even if, as I mentioned to you, in 75% of cases, the mixed one in the left atrium, we will go through the left atrium and we will go we can also go through the right atrium, and we will remove this near the fossa ovalis. We will remove this fossa ovalis, and from the right atrium, we will remove the myxoma. Sometimes we have to put the left atrium, the right atrium, because the myxoma is so big that we want to go to both the right and the left atrium to be able to remove the myxoma. The most important thing again is to remove the site of insertion. So we are very careful to see. I did one case, I remember one of the first cases I did in France when we was training. I removed the myxoma. I made a big hole in the roof of the left atrium, and we had finished the surgery, and blood was coming, and we didn't know what was happening. Then my professor came, and he helped me, and we found that I had made a hole in the roof of the right of the left atrium. Depending on GT, it is between the aorta and the main pulmonary artery. The bleeding came from there, and we have to repair this. Next slide, please. So you can see how we are removing this myxoma. This is a case that we did at the Cardiac Center. You can see the two vena cava, superior vena cava and inferior vena cava, and we are removing the myxoma. You can see how fragile it is, and here we have been able to remove the whole lump. It happens sometimes that we have to remove it in small pieces, and we have one new tool in Mauritius that we have adopted in Mauritius is a spoon. We use a spoon to remove the myxoma. We go underneath the myxoma, and with the spoon, the big spoon, the spoon that we use in our kitchen, we will remove this myxoma like this in steps to remove the myxoma. Next slide. So we must be very careful. There can be some challenging situations, like when the myxoma is closed. Do a small hole in the bottom gap. When we have removed the myxoma, we should check everywhere. We have left the insertion side, we haven't done all in the mouth, we haven't done all in the sector, we have moved. Hello? Yes. So we're going to be very careful with this, and we should give application on the base. Can you hear me? Is it okay? It's okay? Okay. So we are going to be very careful. So next one, I'm going to conclude now. So next one, please. Next slide. So myxoma, they are rare tumors. Most of the time they are benign, but the consequence can be fatal. It's an emergency. We have got going very quickly. We have got to perform it. It can be a very easy surgery, but then it can also be very challenging. And we must always be prepared to see things that we haven't seen pre-operatively. We must be very attentive. We must pay a lot of attention to remove the base. Pay a lot of attention not to create insufficiency or damage the valves or leave a defect in the structure. So thank you very much. Last I thank my I hope I have contributed to your meeting. And I can answer any questions if there are questions. Yeah, thank you very much, Mr.
Thank you for the wonderful presentation. Thank you for joining. And it's good to learn about the tumors and what you are doing, your work. And the stage is open for question and answer. If the audience would like to ask any questions.
Hi, Dr. Gunness.
Hi.
Nice to see you again.
Nice to meet you.
In terms of the type of tumors that we see in this part of the world, is it different, say, from the Western world, like from America or Europe?
Well, you know, look, we see many mixed tumors. There might be other tumors, but might be our diagnostic pathway is not well established, and might be we go, you know, we don't see the others because the patients pass away. You know, we see the two things that we see in the cardiac center. There will be pericardial effusion. Patients are referred to us because of pericardial effusion tamponade, and when we do biopsy of the pericardium or when we analyze the pericardial fluid, then we see a lymphomas. And the other one, they are myxomas. You know, we can also, we see also fibromas that I won't talk about. They are extrapericardic, or we can help the ENT surgeon with fibroma that come in the mediastinum. This is also quite often. And we work together with the ENT surgeon. But the one that we see and the one that is an emergency, the one that we try to do really very quickly is myxomas. In our part of the world, my whole message for the young doctors listening to us in the room is that when there is a thromboembolic event, always do a cardiac echogram. Always do cardiac echogram. If you are in a situation where you cannot explain fever, where you cannot explain loss of weight, don't forget the heart. You know, we tend to think about kidneys, about lungs, about prostate, about the abdomen, about bowel, but don't forget the heart. There can be surprise in the heart. And really, it's not a difficult surgery. It's not a difficult surgery. I would say, you know, it's a straightforward surgery. You just have to be careful and do all the things that we have learned to do step by step, but otherwise it's not a difficult surgery. You know?
Any other questions from the audience? One question. Good afternoon, Dr.
Good afternoon.
I just want to know how many cases are there in your cities?
How many cases? What?
Of the myxoma you have in your experience?
Oh, in my experience, look, I have been doing surgery since 1986. Yeah, I've seen a lot of myxomas. In Mauritius, we see about 4 or 5 every year in the public and private sector. But since, you know, quite a few years of surgery now, in other parts of the world, you know, like Botswana, we see Madagascar, we see in France, where I was working, I've seen a lot of myxomas. Very often, myxomas, they are the first surgery that the professor will give to the young surgeon. So the young surgeons, they will train on myxomas. There are a lot of tricks, you know, it's like a puzzle. Where you've got to go, where you've got to remove this, and what you've got to be careful with this, with this, with this. They are not, you know, not just like bypass surgery. You see the bubble like a microscope. We go and do the work itself. But myxoma, you've got to look around you and to be very careful. So I don't know the numbers, but I've done many more cases of myxomas. Thank you.
Dr. Gunness, I had one question. I gave a talk earlier on cardiac MRI. Do you use cardiac MRI to assess your patients with tumors?
We are going to use it more and more. We now have the facility of doing it. We have got one specialist who is very well trained in cardiac MRIs, who has joined us from Australia. I'm sure he will be very helpful. I'm sure it is a very good diagnostic tool, and we will do more and more. And this cardiac MRI can help us in many of the situations. I'm sorry I was not there to listen to you, and I will ask Dr. Banerjee if I can have your presentation. I'll be so happy to go through it.
Thank you, Dr. Gunness.
Thank you so much.
So we'll end the session over here.
no more questions. And I'd like to thank Dr. Gunness for joining. Hope to see you next time in person.
I will.
And thank you for accepting our invitation to be a
Thank you so
speaker.
much.
And,
Thank you for having me. Thank you for having me. And again, apologies for not being there in time.
Thank you so much. See you next year. Thank you.
Keep going. Bye.
Thank you, Dr. Ganesh, for the insightful session. I would like to invite Dr. A.P. Singh to give certificates to our chairs. First, I would like to call upon Dr. Derek. Dr. Banerjee. Thank you, everyone. And we proceed to the closing ceremony.
And so, just like that, we reached the end of the ceremony, and it's been a very long journey, filled with many, many moments, and wonderful discussions and PowerPoint presentations. And as Dr. Sushil had mentioned before, all the students who have participated in the poster, congratulations. You guys will be the pillars and the foundation for the future to come. And we truly hope that all the hard work we have today will be fruitful in the future, because these are the steps of the growth that all of you guys will have. And it is a piece of SSR that remains in all of you as you move forward. And to all the presenters and the organizing community and to all the members here today, we thank you very much for the session. And before we end, we would like to give a few certificates. Now, even though everybody is a winner, we must have a third, second, and first place. So for the prize distribution, we'll be handing out the posters for the third, second, and first place. Now, does anybody have any guess who it will be? So, in third place, with a fantastic poster presentation on the climate change and health, it's poster number 22 with Sejo. Please call on stage Dr. Professor Derek to hand over the certificates for our wonderful prize winners. Now, moving on to second place on something quite important for all of us, sleep quality. So poster number 5. first place, which was a very tough battle, we have, drumroll, the perception of bedside teaching in internal medicine wards amongst medical students, poster number 10. Now we'll be going on to the distribution for certificates for the organizing committee. Professor Derek, could you please have you back on stage? So can we please have the organizing vice chairman, Dr. Sushil Dalka? The organizing secretary, Dr. Indrajit Banerjee. The organizing committee member, Dr. Faraz Ahmed. And of course, the organizing chairman himself, Dr. A.B. Singh. Could we please have all the organizing committees for a group picture, please, on stage? So we'll have the two guests, Dr. Grace, please come on stage. Mrs. Milima. Now we'll be having the resource persons and guides.
I'd like to call first Dr. Sushil. Dr. Ranjit. Dr. Saranja Ray. Dr. Herschel Sabane. Dr. Sabir. Dr. Nikhil Ranga.
Dr. Amarendra. Dr. Sanjay. Dr. Miri. Dr. Rama Srivastava. And last but not least, Dr. Banerjee. Now we'll be distributing our certificates to our faculty. Dr. Reshmi, Dr. Tinusha, Dr. Ranjit. Dr. Sanjay. Dr. Ray. Dr. Suranjana Ray. Dr. Sanya. Dr. Rama Srivastava. Dr. Gupta. Dr. Banerjee. Dr. Amarendra. Dr. Bharati Bias. Dr. Miri. Dr. Nitya Ramnath. Dr. Faraz. Dr. Harshal. Dr. Kumar. Dr. Steve. Dr. Rafi. Dr. Neil. Basta. Dr. Anjubala Singh. Dr. Kumar. Dr. Teeluck. And we give this personally to Dr. Abel. And now for our students.
May we please call on stage Dr. Sushil. I'll have to hand over the certificates to all the students. And yet again, congratulations to all the students. We'll be calling on stage the title for HPV vaccination awareness and attitude amongst medical students. Nikhil, Gobind, Akadesh. We'll have person number 2, the burnout among medical students, medical undergraduates. We have team 3, get ready please. Medical student, experience and perception of ChatGPT and artificial intelligence. Antibiotics to assist awareness amongst medical undergraduates. Sleep quality score and its correlation with absence among medical students. Narsha Kala, Ashma, Ritesh, and Sarah. The next team of efficacy of the case-based approach and enhancing critical thinking. Namita, Krishna, Ramesh, the next team of Screen Timeless Association with Sleep Quality amongst medical graduates, Deepika, Mushira, amongst preclinical and clinical medical students. We thank Dr. Sushil for his incredible smile and patience on stage. Can we please call on Indrajit Banerjee to hand over? The next team will be on upper back and neck pain in medical students, something we all suffer from. The next team is perception by bedside teaching in internal medicine. The next team is awareness of menstrual health and hygiene amongst female medical students. The awareness of menstrual health and hygiene amongst female medical students. The next team will be blood group distribution and its association with bleeding and clotting time. The next team is emphasis of hybrid versus physical teaching and learning in surgery. The next team is career preference of medical undergraduates, influencing factors, trends, and gender differences. The next team is time management practices and stress amongst medical students. We'd like to thank Dr. Banerjee for his presence on stage and handing all the certificates to the very, very hard-working students. May we please call on stage Dr. Faraz to hand out. And for the team, it is the assessment of digital device use and visual complaints amongst medical students. The next team is beyond BMI, is waist to hip ratio a key parameter to blood pressure health amongst medical students. The next team is case-based learning versus lectures in pediatrics, education, impact on moms and medical students. The next team is preference in terms of absence among second-year medical students. The next team is impact of case-based learning on comprehensive biochemical pathways in metabolic disorders. The next team is research knowledge, attitude and practice amongst undergraduate medical students. The next team is climate change and health, medical student knowledge, perception and behavioral response. And the last team is sports participation and injury, prevalence amongst undermedical graduate medical students. And another huge round of applause for all the students for their hard work. Now, the last release of the certificates, of course, for those hardworking personnel who are working behind the scenes, tirelessly setting up, organizing, and working hand in hand with all the teachers here. We'd like to call on stage Dr. Sushil to hand out these certificates to Kumar. So, are you ready? Thank you very much. Juliana. Ashna. Sit down. amazing color. Me, myself, and I.
Thank you, Dr. Sushil. Now we'd like to have Dr. Derek to share some final statements on your experience, a conclusion for our conference here today.
Great, well thank you very much. I've really enjoyed today meeting with the students and given the opportunity to present some of our work today. I was really impressed with the work that the students have put in such a short period of time to be able to do those research projects. I remember the last time I came, Dr. Indrajit had arranged a meta-analysis, and I think to actually do original research in such a short period of time and to present such high quality data. And some of the groups I saw had handouts and posters, so that's fantastic work to all of you. And I want to congratulate again Professor Singh and Professor Indrajit on such a wonderful and successful conference, and thank all the local organizing committee. And hopefully I can attend next time, so you can invite me. Thank you.
Now some concluding remarks from Professor Dr. A.P. Singh, our principal and our organizing chairman.
So good afternoon, everyone. So we have reached the final stage, and it requires only my gratitude and thanks to all of you who have participated, Dr. Derek, Dr. Mishra, Dr. Gunness, again offline or online, not offline, faculty members and the students. I'm really hopeful that you have learned something which will help you in future, and you carry your flag as well as SSR flag forward. Thank you.
And now for a vote of thanks by Dr. Banerjee.
Good afternoon, everyone. So I'd like to thank all the individuals who have helped us for the success of this symposium. First of all, I'd like to extend my heartfelt gratitude to our Honorable Chairman, Mr. R.T. Singh, for giving us this opportunity to hold such a conference for the third time. I'm grateful to Dr. A.P. Singh, Principal Assessor Medical College, for always supporting and for always encouraging me and standing by me always and supporting me. Thank you, sir, for all your support, and always you have given me power to walk and think beyond my boundaries. Thank you, sir. I appreciate the support of organizing Vice Chairman Dr. Sushil, again for always supporting, and thank you for always blessing me. As I mentioned in the last conference, I have been his student once when I was in medical college as an undergraduate medical student. Thank you, sir. So I like to thank Dr. Faraz. Dr. Faraz, I hope I don't see him. Yeah. Thank you again, like last time. Like he has helped us with the great designing for the abstract book, what you got. The banners, thank you, Dr. Faraz. Hopefully, you will help us next year as well. I want to thank the keynote speakers, especially Dr. Derek. So I am frequently meeting him every year. So hopefully we'll meet you again soon at SSR Medical School or any other conference. Thank you, Dr. Derek, for joining us. I'd like to thank the other keynote speakers as well, Dr. Ganesh for joining us online, as well as Dr. Jackal Mishra, who has accepted our invitation for this symposium. I appreciate the efforts of all the resource persons for the pre-conference workshop. I'd like to mention because they have always helped us for training our students for the research methodology workshop. Although many of the students were not sincere, but I would say it is important to start because we never know that where you will go, where you will reach later on. Many of you will be taking research in future. It will be useful for you. You will realize it later on. So the resource persons were Dr. Sushil Daukar, Dr. Harshal Sabane, Dr. Shudir Jha, Dr. Suranjana Ray, Dr. Ranjit Patil, Dr. Sanjay Deshpani, Dr. Amandra, Dr. Nikhil, Dr. Mayuri, Dr. Lama. Thank you everyone for your help and support. I appreciate the efforts of all the student participants. Yeah, I'd like to share a few things like what I felt personally. I'd like to share with you. There was one deadline that was given to all the students. Like you have to submit your abstract and the poster by 23:59 hours before midnight. That was the deadline given to all the students. And you will be surprised to know that I have received all the abstract and all the posters before that deadline. So I would say that there were few winners, first, second, third, but that day only I thought that all of you were winners because if our target is set, and if a proper path is shown, this young and energetic student can reach any level. I am thankful to all the faculty members and non-teaching staff who were directly or indirectly involved for the success of this meeting. I am thankful to the Department of Pharmacology, the HOD of Pharmacology, Dr. Gupta, Dr. Amarendra, Ravi, Priti for their help. Special mention about Ms. Kirti and Mr. Jatin from the front office for the logistics, Sharmila and Deepa for their support. I'd like to mention about student from semester 10, Mr. Tabriz. Tabriz has helped us with the posters, for printing the poster. There were some issues, but I would say that he has done a great job because it's not easy to print all 23 posters. So I would say that we should appreciate him as well. I'd like to extend my deep appreciation to the volunteers. So always they were hardworking, always supported me and in difficult times. So a big round of applause for all the volunteers who have worked very hard. I'd like to mention a few names, those who are working with me and who is constantly helping me and assisting me for the last 3 conferences. So last 3 international event, Mr. Nikhil now, next year he will be Dr. Nikhil, Amnik Singh and Ilona and Kelly. For them, this was the 3rd time and they are organizing it with me. So big round of applause for them. All of you have seen the effort they are putting, and I have identified them when they were kids. They were in 4th semester or 6th semester. I have identified them. Still they are with me, helping me, and hopefully let's see next year maybe Nikhil, Amnik, and Kelly won't be with us. So maybe you can join as an intern next year and help us. I would like to sincerely thank the Medical Council of Mauritius for awarding 3 CPD points for this event. I am confident that we will continue to host similar events in future, keeping the flag of SSR Medical College flying high. Thank you and hope to see you next year.
opportunities and having these events for us here at SSR. So now, we'd like to finally end our session. I'd like to thank you all for your time, your insight, and your energy throughout this conference. Your contributions have made it a true success, and we look forward to seeing you all again soon. So safe travels, and thank you. And we'll have our group photo now, and those of you with our feedback forms, please hand them in at the front table. Thank you.
We'll be passing for a group session photo right now. So all the faculty members will be from the second row seated on this side. And as from behind, all the students will be placed there, please. And we shall have the camera taken from the front. And then everyone, don't forget to smile.
Yeah, sure. I'm not walking.
Sorry?
अम्मी को पता है
Sorry? That's okay.